For the evidence-based paper and presentation, I chose to address oxygen use and COPD, the nurse practitioner role. This is by Lois Emma for Nursing 712 Research and Evidence-Based Practice. This is a layout of my presentation. We'll go through introduction, background, PICO question, case study, literature review, implementing evidence into the APRN role, and summary and ethical decision-making implications. Onto the introduction. Chronic obstructive pulmonary disease, also known as COPD, is a condition that affects 11.7 million adults in America. The disease results in thousands of emergency room visits and tens of billions in healthcare costs per year. It is the sixth leading overall cause of death in America, only after heart disease, cancer, COVID-19, accidents, and stroke. It is also important to note that 85% of COPD deaths occur among persons aged 65 or older. But the prevalence of COPD is high among ages 45 and above, with the highest rates among those over the age of 85. So the older the patient, the worse the prognosis. Background. Nurse practitioners play an important role in the primary care management of COPD. 83.2% of full-time nurse practitioners tend to Medicare patients. Medicare patients tend to be 65 years and older, and therefore nurse practitioners have the opportunity for early diagnosis and patient counseling. Risk factors for COPD include cigarette smoking with occurrence rates being 7 times higher for current smokers and 4 times higher for former smokers. Other risk factors are low family income, higher rates of anxiety and depression, presence of disability, lack of influenza and pneumonia vaccination. Most of these risk factors can be addressed at primary care visits with a nurse practitioner, and with proper counseling, most patients can avoid worsening or obtaining the disease. In America, 28 states permit nurse practitioners to obtain full practice authority. However, not all these states permit for the nurse practitioners to prescribe durable medical equipment such as oxygen. According to Bupart 2021, the only states that allow for APRNs to prescribe DMEs are Arizona, California, Delaware, Montana, and Pennsylvania. For Colorado, the Department of Regulation's website states that APRNs can prescribe DMEs, but it has to be within their scope of practice. The only clear example that was given on the website is that certified nurse midwives could prescribe breast pumps. However, there was no clear answer as to whether family nurse practitioners could prescribe oxygen. The World Health Organization reports that at least 1.4 million people die every year due to the lack of supplemental oxygen therapy. Another risk factor to low oxygen is high altitudes in states such as Colorado, which can cause low oxygen saturation levels due to low atmospheric pressure, and this can greatly burden patients suffering from COPD. There is no doubt that the prescription of supplemental oxygen to those that need it is a significant health risk factor. Now for the PICO question. Are advanced practice nurse practitioners with prescriptive authority, our population, for supplemental home oxygen, the intervention, able to better manage patient COPD symptoms over time, outcome and time, or does limiting the prescriptive privilege to physicians only not affect disease outcomes? In this presentation, we seek to address this question. We'll start with a case study. Our patient is Mr. Jones, and he's a 70-year-old male that resides in high-altitude North Carolina. North Carolina is one of the states that do not allow for full prescriptive authority for APRNs to begin with. Mr. Jones is a former tobacco smoker that smoked 2 packs a day for 30 years, and he quit 5 years ago when he was diagnosed with emphysema. Despite his recent lifestyle change, his disease is now a severe case of COPD. Mr. Jones resides in a rural area where there are no specialists in his or his neighboring counties. He does receive primary care from a clinic in his town that is primarily staffed by several nurse practitioners and a supervising physician. And Mr. Jones does do his best to follow up with his doctors and get his immunizations. However, due to his chronic condition, Mr. Jones was referred to a pulmonologist a few towns over, but he has not been able to obtain transportation to get to the appointment, so that is a barrier for him. Earlier in the week, Mr. Jones experienced increased shortness of breath and increased difficulty with activity. His oxygen saturation was 88% at rest and 80% with activity. Mr. Jones went in to see his primary care provider, but the attending or the supervising physician was not in clinic because he was out of office and out of town due to family emergency. The nurse practitioner obtained a chest x-ray and determined that it was not a pneumonia infection. The NP also ran a respiratory virus panel at the clinic lab and ruled out the flu. And the nurse practitioner canceled Mr. Jones to immediately go to the emergency rooms if symptoms do not improve. Now, because of the limitations of authority that the nurse practitioner has, Mr. Jones could only get additional breathing treatments, some steroids, but he could not get a prescription for oxygen. When he left the office, his oxygen saturations had improved to 89% with activity, which he was told is permissible for COPD patients. However, a few days later, Mr. Jones called an ambulance to his house for hypoxia. He was having trouble breathing, and he was found with an oxygen saturation level of 75%. Mr. Jones was then admitted to the hospital for a week for treatment of hypoxia and pneumonia. Now, the big question in this case study: could the hospitalization and pneumonia infection been avoided had the nurse practitioner been permitted to prescribe portable oxygen? We will look into evidence-based practice on COPD treatment and see if there is a link. Onto the literature review. COPD management has clear clinical practice guidelines, and treatment of the disease consists of a multifaceted approach. This approach addresses causative factors, symptom management, and the prevention and management of condition decline. It is very important for patients with COPD to have easy access to primary care providers that can help them adjust their medication or address their needs accordingly. The American Lung Society established clear treatment plans and recommendations for managing COPD and controlling flare-ups. These clinical practice guidelines have been revised with the development of new medications. With ever-changing technology, different medications are created, and the American Lung Society does make it a point to stay on top of the new types of therapies that have come up to see if they can improve the prognosis for COPD. According to the clinical practice guidelines for managing COPD, there are 4 treatment categories that need to be followed. The first is baseline medication therapy with a long-acting beta agonist, LABA, and or a long-acting muscarinic antagonist, LAMA. An example of a LABA is formoterol. An example of an antagonist is tiotropium. Step 2 would be addition of an inhaled corticosteroids for uncontrolled symptoms, such as budesonide. Third would be low-dose opioid treatment for the treatment of refractory dyspnea, and the preferred medication for this is extended-release oral morphine. The fourth treatment category is long-term oxygen therapy of at least 15 hours a day for patients with resting hypoxia, and this is considered an oxygen saturation of less than 88%. Now, the above recommendations were made by the American Thoracic Society, but the available evidence for COPD is too limited to make recommendations for patients that are over 80 years old, or those that suffer from comorbidities such as asthma, eosinophilia, and other chronic conditions. Evidence-based interventions. Why oxygen? Supplemental oxygen was the first treatment ever shown to prolong life in people with a diagnosis of COPD. A multidisciplinary panel was created by the American Thoracic Society in order to address oxygenation recommendations for patients with COPD. This is because hyperoxygenation is a risk factor when using oxygen on COPD patients. and there has to be a gentle balance. So the American Thoracic Society sat down and created specific recommendations as follows. There is a strong recommendation for the prescription of long-term oxygen use for COPD patients with severe chronic resting hypoxemia. There is a conditional recommendation against oxygen prescription for COPD patients with moderate chronic resting hypoxemia, which is 89 to 93%. And we see that a lot in the hospital setting where a patient would have an oxygen saturation of 89%. You notify the physician and they say they have COPD, they're fine. Just notify me if it's less than 87 or 85, whatever parameters you choose to give. There was also a conditional recommendation for the prescription of ambulatory oxygen for COPD patients that experience severe exertional hypoxemia. Partly the reason for this is because patients with COPD do not take a full deep breath. So despite the supplemental oxygen in their nares, they may not still be able to get the full benefit of the supplemental oxygenation, especially with ambulation. Lastly, there's a strong recommendation to prescribe liquid oxygen for active COPD patients that require continuous 3 liters or more supplemental oxygen. And of course, in addition to all this, there must be patient and caregiver education on oxygen equipment and safety. Implementing evidence into advanced nursing practice. Because treatment of COPD cannot be efficient when done by the nurse practitioner alone, the adaptation of the middle range theory of chronic care model is appropriate. The chronic care model utilizes a patient-centered disease management approach to systems and care teams, especially when a goal-oriented approach is utilized. Patient-driven self-care interventions include smoking cessation, avoidance of secondhand smoke, medication adherence, treatment plan adherence, and close monitoring of status and condition changes. In collaboration with the clinical practice guidelines for treating COPD, the APRN and patient should have everything available to monitor patient tolerance to the recommended medications, oxygen saturation trends, hospitalization frequency, and symptom management such as ambulatory hypoxia. However, when APRNs lack the authority to prescribe home oxygenation devices, it does limit their ability to better manage COPD. Over 1.5 million people suffering from COPD require supplemental oxygen, but many challenges exist in getting the right type and levels of oxygen. Some of these challenges include finding a prescriber that can prescribe it to you, finding a DME supplier, having confusing equipment of choices for oxygenation, inadequate physician and patient education, stigma and perception of using supplemental oxygen in public, and the emotional impact of carrying supplemental oxygen. The patients do realize that they require the oxygen, but there are some barriers that are at the back of their minds, and a lot of people do struggle with these. Nurse practitioners with a holistic approach can address some of these issues involving education, awareness, and support for COPD patients. Ethical decision-making considerations and implications. The average cost of patient seeing a nurse practitioner is lower than that of seeing a physician. Boards of nursing should place prescriptive authority for oxygen and other DMEs in their APRN scope of practice. If an APRN is given the authority to prescribe supplemental oxygen for a patient without having to first refer them to a specialist, there would be reduced hospitalization rates, improved patient satisfaction, and reduced burden on the healthcare system as a whole. Supplemental oxygen to qualifying COPD patients would improve patient safety and overall quality of life. Summary. There is no argument that poorly managed COPD often leads to frequent exacerbations, hospitalizations, and higher mortality. Patients that have COPD are said to experience a similar symptom burden as those with lung cancer, only that COPD patients often miss out on palliative care due to the unpredictable nature of the disease. COPD does need to be managed using a holistic approach, and that is considered the nurse practitioner specialty. Nurse practitioners are at the forefront of holistic approaches to chronic illnesses due to their education, skills, and compassion, which advocates more for patient empowerment and patient education. It is my opinion that all APRNs should have the authority to prescribe DMEs, including supplemental oxygen, in order to fully explore all treatment options with the patients without an extended wait time for referrals or increased costs due to unplanned hospitalizations. Assessing patient oxygenation is a basic nursing skill, and therefore, highly educated APRNs should have the authority to assess the qualification for supplemental oxygen used for COPD patients, and also those with interstitial lung disease. Finally, these are my references.